All right. Hi again. I am Erin Abramson, and I would like to welcome you to today's CDC Partner Update call on COVID-19. This call serves as a way for CDC to share weekly updates on COVID-19 and our latest resources and guidance, especially for the private sector and other partners. Today's call will focus on what you need to know to stay healthy while traveling during the pandemic. We will hear from our COVID-19 response Chief Medical Officer on where we are with the response and about what everyone should know about protecting themselves and others. We will then turn to our subject matter expert who will discuss CDC's toolkit for domestic travelers. Afterwards, our speakers will take questions from the audience. Please note, this call is intended primarily for CDC partners directly involved in the COVID-19 response. Should media who are listening now have questions, they're welcome to reach out to media@cdc.gov. This call will be recorded and later posted on the CDC COVID-19 website, as well as on YouTube. All past partner calls can be found there, so please take some time to review and share prior recordings. If this is your first webinar with us, these weekly calls occur every Monday at 3 p.m. Eastern Standard Time. Please see the link in the chat box to subscribe to our mailing list to receive future CDC COVID-19 Partner Update webinar invitations. Note that there are multiple listservs that support this call. So if you feel you have missed an invitation over the last few weeks, please click the link in the chat box provided to ensure you are on the listservs. I would also like to remind participants that the CDC website has the latest information, guidance, and communication resources. There are over 2,000 documents providing information and guidance for individuals, businesses, and the public on our website. In addition to the tools we'll highlight today, some resources posted within the last 2 weeks include new school guidance, including frequently asked questions for school administrators on reopening schools, a school decision-making tool for parents, caregivers, and guardians, back-to-school planning checklists to guide parents, guardians, and caregivers, and guidance for K-12 school administrators on the use of cloth face coverings in schools, along with screening K-12 students for symptoms of COVID-19, a limitations and considerations document. We also have a toolkit for people with disabilities around health equity considerations and racial and ethnic minority groups, and a considerations for retirement communities and independent living facilities document. We've had a lot of stuff going on right now. COVID-19 travel recommendations by country. We want to thank all of those who sent questions to us in advance. We've already teed up a few of those questions, and I'll keep an eye on the Q&A box, so please feel welcome to submit questions there as well as we go. Note that we will not be viewing the chat box. We'll use the Q&A box. So please utilize the full functionality of the Q&A box. I'm very pleased today to be joined by two CDC experts, Dr. John Brooks, the Chief Medical Officer for the COVID-19 response, and Dr. Ali Walker, Epidemiology and Surveillance Lead for the Travelers' Health in CDC's, sorry, I'm going to get this wrong, Global Migration Task Force in the COVID-19 response. For those of you logged into the webinar platform, there will be very few slides used today, so please don't be alarmed if they do not seem to be advancing. I'd like to turn it over to Dr. Brooks now for some updates.
Thank you, Dr. Abramson, and welcome everyone for joining us today. I see that we've got about 400 so far, and hopefully some others will continue to straggle in. My name is Dr. John Brooks, as Dr. Abramson mentioned, and I'm the Chief Medical Officer for CDC's COVID-19 response. Today, I want to provide you a brief update on the COVID response here at CDC and some of the latest scientific developments and guidance. So let me remind folks, just set the stage here, that globally, there have been over 5.5 million cases so far. We're rapidly approaching 16 million, and I read in the news we may be there already at this time, and over 635,000 deaths, and that's as of July 25th. Here in the US, there have been over 4.1 million confirmed and probable cases reported to our agency, the CDC, and tragically, over 146,000 deaths, which represent 25% of all cases and of all deaths reported worldwide to date since the beginning of the pandemic, which is also more cases and deaths contributed by any other country. The three other countries following the United States are Brazil, India, and Russia. Nationally, now focusing on the United States, new diagnoses have continued to rise, although preliminary data this week suggests we might possibly be slowing or approaching a plateau. However, there remains substantial variation by state, with some states in an acceleration phase, while others have plateaued and still others are in a downward trajectory. The number of new diagnoses, so overall, continues to steadily rise throughout the country. And we're continuing to see an increase in deaths since the end of June and beginning of July, after a period of steady decline. And I'll just remind you that deaths are a lagging indicator, so we might expect them to go up following a rise in new cases. As I noted, the duration and severity of the pandemic are varying by state. Achieving control will continue to depend on a strong public health response, including increased access to testing and widespread adoption of what we call non-pharmaceutical interventions, or you may have heard NPIs before. And these include some things I hope are familiar to you, like social distancing, hand hygiene, face coverings and masks in public when you can't stay 6 feet apart from other people, covering your cough or sneeze, and avoiding touching your face. We also recommend routine disinfection of high-touch surfaces like doorknobs and faucets and other things you may touch frequently, increasing ventilation to keep the air diluted, and of course, closely monitoring your own health and the health of your loved ones for possible illness. We encourage you to visit CDC's COVID View webpage, and this has a weekly summary and interpretation of key indicators that have been adapted to track the COVID-19 pandemic in the United States. So let me move on now and briefly discuss some ways that we can help minimize stigma and disinformation. Misinformation is a critical piece of something that all of us can help control, and I want to give you some information to help you help us do that. First, we all need to fight stigma. We can do this by supporting people who are coming back to work after completing their quarantine or their isolation period for COVID-19 exposure or illness, whichever it was. Anybody who has completed their quarantine or met the requirements to discontinue infection control measures and isolation does not pose a risk of spreading COVID-19. People of Asian descent, including Chinese Americans, are not any more likely to get coronavirus than anyone else. Let people know that being of Asian descent does not increase the risk of getting or spreading COVID-19. Viruses cannot target people from specific populations, ethnicities, or racial backgrounds. We are all equally at risk. People who have not been in contact with a person who is a confirmed or suspected case are not at greater risk of acquiring and spreading this new virus than anyone else. And people who've returned from an area of widespread or ongoing community spread and have been back for more than 14 days, that means more than the incubation period it takes to get ill, and if you don't have symptoms, then you're not a risk to other people. So if you're coming back from an area where COVID has been reported and it's been more than 14 days, you don't pose a risk to others. You all can help us counter these myths and rumors by sharing accurate information about how the virus spreads. And in addition to COVIDU, our website, www.cdc.gov/COVID or COVID-19 can help take you to other information to get you up to speed. It's important that all of us speak out against negative behavior, including negative statements on social media about groups of people or exclusion of people who pose no risk from their regular activities. All right, now let me turn to a medical update. And what I'd like to do is share some information we've learned from 3 recent seroprevalence studies that took place during April and May. Seroprevalence studies are studies that look at the antibodies to the virus that a person develops after they get the infection. And these antibodies appear in their blood, and we measure them in their blood. Finding antibodies indicates that the person was likely infected at some point since the start of the pandemic. Large-scale serologic testing can be used to provide population-based estimates of infection that include people who had just mild or asymptomatic infection and who may never have been tested despite having symptoms. Serologic studies are also important because reported cases likely represent only a fraction of COVID-19 illnesses, as an unknown proportion of cases are mild or asymptomatic, or they may otherwise have not been diagnosed or been ascertained through our passive public health reporting system. So I said there were 3 studies, and the first one I want to talk about was detailed in last week's MMWR and looks at statewide seroprevalence from the state of Indiana during April. This was the first statewide random sample seroprevalence study the agency conducted. The results of this large statewide population prevalence study indicate a population prevalence of about 2.8%, meaning that among all Indiana residents, an estimated 187,802 were infected with COVID-19 from the start of the pandemic through the date of the survey, which ended April 29th, 2020. At that point in time, Indiana had only confirmed and reported roughly 18,000 cases, which is less than 10% of what I just described the seroprevalence study suggests. So the number of tests that found active infections suggests at this time that early in the epidemic, based on the total number of infections, the infection fatality rate, that is the number of all infected people who died, was 0.58%. This is about 6 times the rate that we see for influenza for the same estimate, for the number of all people estimated by seroprevalence who have died. The research team also had some other really important findings I'd like to share. The first is that they tested participants for active infection, and among those persons they also tested them for active infection, and among those who had active infection, 44% reported no symptoms, and this is within the range of other estimates that suggest that anywhere from 15 to 45% of infected persons don't have symptoms at testing or never go on to develop symptoms. The study also found the prevalence of current or previous infection was significantly higher among Hispanics. The prevalence for Hispanics was 8.3%, compared with non-Hispanics at 2.3%. That's over 3.5 times higher among Hispanics than non-Hispanics. This finding highlights the need both for communication strategies tailored to the culture and to the languages of the local community, as well as conducting more testing and contact tracing and directing those resources to these kinds of areas to prevent additional infections among these racial and ethnic minority groups who may be at higher risk. The significantly higher observed prevalence minority communities might have been due in part to social conditions that increased transmission opportunities, including minorities being disproportionately represented among essential workers, like factory workers. This is an example where in these sorts of communities, our colleagues in the clergy and in the community leaders can be really helpful, reaching out to community members and increasing their trust in and engagement in our testing programs, because testing is the gateway for preventing this disease. A second MMWR, also run by CDC, was done in 2 counties that make up the metro Atlanta area. Investigators did a door-to-door household survey in these 2 counties between April 28th and May 3rd, 2020, and found an estimated 2.5% prevalence of persons with detectable antibodies to the virus. This finding suggests that the great majority of the population in these counties has not been infected with the virus at the time of the survey. Which was conducted through May 3rd, and that was right about the end of the statewide shelter-in-place order here in Georgia. Only about half of seropositive persons, that is persons with detectable antibodies to the virus, recalled ever having an illness compatible with COVID-19. These findings then also highlight that many SARS-CoV-2 infections would have been missed if we'd only gone based on symptoms, so using what we call a case-based surveillance that requires a person to seek out medical care in the healthcare system to get a test or otherwise get tested for SARS-CoV-2. These infected persons would also have been missed by syndromic surveillance, which is another method we use that tracks reports of symptomatic illness. Seropositivity in this survey was associated with being of non-Hispanic Black race ethnicity. Although the number of seropositive persons in the survey was small, this finding is consistent with other reports, including the one I just described, that indicate persons of minority race or ethnicity are being disproportionately affected by COVID-19 in this pandemic. Lastly, third study by CDC appeared in a large publication this week, and this was a much larger study that looked at 10 diverse geographic areas in the United States and had different discrete data collection periods for each area, varying at different times from starting in late March all the way through the mid part of May. And this report appeared in the Journal of the American Medical Association, or JAMA. Seroprevalence estimates varied across these 10 diverse areas by as low as 1% in the San Francisco Bay Area, conducted in late April, and as high as 6.9% in the New York City metro area in a survey conducted in late March. When these data were compared to the number of cases that had been diagnosed and reported in each of these 10 sites, the seroprevalence data that are new now suggest that the estimated number of true infections was actually somewhere between 6 to 24 times the number of reported cases, and it varied by the jurisdiction. It's thus very likely that many infections were asymptomatic, produced only mild illness, for which healthcare was not sought, and that some symptomatic ill persons either did not seek did not seek care or were not tested. I just want to point out that there are three important conclusions I want to make sure people draw from this study. From this study. First, the seroprevalence estimates from the JAMA report suggest that at the time of specimen collection, which again was March to early May, a large majority of persons in all 10 of these geographic sites had not been infected with SARS-CoV-2. A lot of people were still at risk. The estimated number of infections was greater than the number of reported cases in all sites. And this finding, as I've repeatedly said now, may reflect people who either were mild or asymptomatic and didn't get tested because they didn't seek medical care. But what's more important about that fact is these persons are still capable of transmitting and could have contributed to ongoing transmission in the population. Because many persons otherwise don't know if they're infected with SARS-CoV-2, the public should continue to take steps to prevent its spread, such as wearing face coverings or masks when outside the home, remaining 6 feet apart from other people to the extent that you can, and washing hands frequently and staying home when sick. So what does all this information I've spent this time talking to you about tell us from these three studies? A couple of things. First, much of the population studied, and like the general population of the United States, has not been infected with SARS-CoV-2 or the illness COVID-19, are still at risk for this illness. So we need to continue these preventive behaviors I've been mentioning, like hand washing, social distancing, face coverings and masks in public places, to protect ourselves, our families, and our communities. Second, there have been many more infections with COVID-19 than reported, indicating that people who don't know they are ill are spreading the virus unknowingly, and certainly inadvertently. And third and lastly, we continue to see disproportionate rates of infection among members of racial or ethnic minority groups, which indicates a need for increased culturally appropriate public health communication, as well as culturally sensitive contact tracing and testing in these communities. We all have a part to play in slowing the spread of COVID-19 in our communities, our schools, and our workplaces. So I've spoken long enough, and I apologize if I went on a little bit too long, but let me hand it over now to Dr. Walker, who's going to share some guidance for traveling.
Thank you so much, Dr. Brooks. My name is Dr. Allison Taylor Walker, and I'm the lead for epidemiology and surveillance at Travelers Health at CDC and the Global Migration Task Force. And I'll talk to you a little bit today about considerations for safer summer travel. We all know that COVID-19 cases and deaths have been reported in all 50 states and that the situation is constantly changing. Because travel increases your chances of getting infected and spreading COVID-19, staying at home is the best way to protect yourself and others from getting sick. If you're thinking about traveling away from your local community, there are a few questions that you should be asking yourself as you're considering these options. Is COVID-19 spreading where you're going? If it is, you could get infected while you're traveling. Is COVID-19 spreading in your community? If it is, then even if you don't have symptoms, as Dr. Brooks was just saying, you can spread COVID-19 to others while you're traveling, unknowingly and inadvertently. Another question to ask yourself would be, will you or those that you're traveling with be able to maintain that 6 feet of distance between yourself and others during and after your trip? Being within 6 feet of others increases your chances of getting infected, and it increases your chances of infecting others. Are you or those you're traveling with more likely to get very ill from COVID-19? Those who have an increased risk of severe illness from COVID-19 should definitely limit their travel and think very carefully when they're considering leaving their local communities. Another question to ask is, do you live with someone who's more likely to get very ill from COVID-19? Even if you're not traveling with that person and they remain at home, if you get infected while traveling, then you can spread COVID-19 to loved ones when you return, even if you don't have symptoms and don't know that you've been infected. A really important question to ask is, does the state or local government where you live or at the destination require you to stay home for 14 days after traveling? Because some state and local governments may require people who have recently traveled to stay home for 14 days. And also, if you get sick with COVID-19, will you have to miss work or school? People with COVID-19 disease need to stay home until they're no longer considered infectious. Along these lines, we say do not travel if you're sick or if you've been around someone with COVID-19 in the past 14 days. As Dr. Brooks just mentioned, if you've been exposed to someone who has COVID-19, even if you don't feel symptoms, you may still be able to spread it. So do not travel if you are sick, if you've been with someone who is sick or has been infected, and do not travel with someone else who is sick. If you do travel, protect yourself and others during your trip. And there are a few ways to do this. And Dr. Brooks went through many of these. We'll say them over and over again. They are the most important things to do during this pandemic. Wash your hands with soap and water for at least 20 seconds, especially after you've been in a public place, after touching surfaces that are frequently touched by others, after blowing your nose, coughing, or sneezing, and before touching your face or eating. If soap and water aren't available, then you can bring and use hand sanitizer that contains at least 60% alcohol. Cover all surfaces on your hands and rub your hands together until they feel dry. You should avoid touching your eyes, nose, or mouth. Avoid close contact with others. And when I say this, we mean keep a 6-foot physical distance between yourself and others. Wear a cloth face covering or mask when you're in public. Cover coughs and sneezes. And we recommend that you pick up food at drive-thrus or use curbside restaurant service or shop in stores where you can maintain a 6-foot distance and wear masks at all times when you're looking for food while you're traveling. Travel increases your chances of getting and spreading COVID-19. We don't know if one type of travel is safer than others, but we do know that at airports, bus stations, and train stations, and even rest stops, these are all places where travelers can be exposed to the virus in the air and on surfaces. And they're also places where it can be really hard to social distance or keep that 6 feet apart from other people. So when we're thinking about how to travel, we want to consider the following risks for getting and spreading COVID-19. We know that air travel requires spending time in security lines and at airport terminals, and this can bring you in close contact with other people and lots of frequently touched surfaces. Most viruses and other germs don't spread easily on flights because of how the air circulates and is filtered in airplanes. However, social distancing is really difficult on crowded flights, and you may have to sit next to others within 6 feet and sometimes for hours at a time. So this may increase your risk for exposure to the virus that causes COVID-19. Traveling on buses and trains for any length of time can involve sitting or standing within 6 feet of others. And if you're traveling by car and making stops along the way for food and gas or bathroom breaks, this can put you and your traveling companions in close contact with other people and, again, surfaces. If you're traveling by RV, you may have to stop less frequently for food or bathroom breaks. But RV travel typically means that staying at RV parks overnight and getting gas and supplies at other public places. Again, these stops may put you at risk, if you stay overnight in a location, there are shared spaces where you may come in contact with others. CDC has more guidance for how to protect yourself from COVID-19 on different types of transportation on our website. We have to think about anticipating your needs, any needs you may have while you're traveling to limit the risk from additional interactions. And you'll see this theme throughout our discussion today. So we recommend that you bring enough of your medicine to last for your entire trip. This includes medications you buy at the pharmacy or prescription medications, even non-prescription medications. If you need some type of medication, we don't want you to have to go into a store and purchase or refill prescriptions while you're in a location where you're not familiar. We want you to be able to do that in a secure setting where you know that you can maintain your social distancing and you have a routine. We also recommend packing enough alcohol-based hand sanitizer, at least 60% alcohol, and keeping it within easy reach. Again, we ask that everyone brings a cloth face covering or a mask to wear in public places. prepare food and water for your trip. You can pack these non-perishable food items in case restaurants and stores are closed along the way. And also that we recommend taking steps to protect yourself from COVID-19 when booking accommodations or planning an overnight stay. Many consider cleaning travel lodgings when they plan to stay overnight away from home, and CDC has great guidance on how to clean and disinfect in these locations. But wherever you go, follow state and local travel restrictions. For up-to-date information and travel guidance, check the state or local health department website for where you are, anywhere along your route, and at your planned destination, because the guidance may differ. And while you're traveling, it's possible that a state or local government may put into place travel restrictions, such as stay-at-home orders or shelter-in-place orders, or they may mandate quarantines upon arrival or even close state borders. So plan to keep on checking for updates as you travel. If you're traveling overnight, you can take the following steps to protect yourself. You can wear a cloth face covering or mask in the lobby or common areas of hotels or lodgings. Check the hotel's COVID-19 prevention practices before you go. And use options for online reservation and check-in, mobile room keys, contactless payment, anything to limit your interactions. Before you go, you can call and ask the staff if they're wearing face cloth coverings at work, and look for any extra prevention practices being implemented by the hotel, such as plexiglass barriers at check-in counters and physical distancing signs in the lobby. You can ask if the hotel has updated policies about cleaning and disinfecting or removing frequently touched surfaces and items like pens and room keys, tables, phones, doorknobs, light switches, elevator buttons, water fountains. There are a bunch of different surfaces that people commonly touch that we don't even notice. ATM cards and payment stations are some. If you need to use a business center, these computers and printers are definitely commonly touched shared spaces. Ice and vending machines are also included in this, and even remote controls in your hotel room. So a lot of this is about just being aware of your surroundings, limiting the things you touch and the space that you share with people that you don't know and whose COVID-19 status you don't know. So we recommend wearing cloth face coverings and limiting close contacts with others, and minimizing use of the areas that may lead to close contact or being within 6 feet of other people as much as possible, like in break rooms, outside patios, and inside lounging areas, in dining areas or kitchens, game rooms, pools, hot tubs, saunas, spas, salons, and fitness centers. We also recommend that you consider taking the stairs or otherwise wait to use the elevator until you can either ride alone or only with the people from your household. When it's possible, you can choose contactless options. And if you're ordering room service, request contactless deliveries. And if you're considering cleaning your lodging, again, look to the CDC's guidance on how to clean and disinfect. And I hope that these considerations will help everyone travel safely this summer.
Thank you so much, Dr. Walker and Dr. Brooks. I know we've tried to do very minimal traveling this summer, but I have 3 kids under the age of 7, so they're getting a little bit stir crazy at home. I should say a lot stir crazy. So we've been doing all of these things and calling and talking to hotels, and they act a little bit annoyed when you go through and ask them for all of their cleaning practices and what they're doing, but you just do it. You ask them all the questions. And so along that same line, we are going to go through a few questions and answers. We have some that we received from our folks that have registered ahead of time. And we're also going to do a little bit of trying to answer in the Zoom Q&A box. So please bear with us as we try to kind of do both, and we'll see if we're okay at it. But our first question that we received ahead of time is for Dr. Brooks. If someone is in frequent contact with a positive case, but less than 15 minutes each time, is that considered close contact? For example, if an employee spent 5 minutes with a positive case on 3 separate occasions throughout the day, that's 15 minutes, but not continuous. So kind of the continuous versus cumulative idea. How would that work?
Yeah, that's a great question. I get this question a lot. And I guess the first thing I want to make clear to folks is this idea of the standard rule of less than 6 feet for more than 15 minutes. I'd urge you to really consider it a rule of thumb to help you identify who may have been a close contact that could spread the virus. You have to consider that in terms of the quality of the encounter. And by that, I mean that, let's say someone sneezes directly in your face. That might last only a few seconds, but I think all of you would agree with me that's a high-risk circumstance. Similarly, two people could be sitting within 6 feet of each other, maybe 5 feet apart, but talking very, very low, or not even talking, just looking at their cell phones. And that may be a lower risk than the kind of 15 minutes we're talking about, which is typically 15 minutes in close contact, which constitutes generally talking or something, having some kind of exchange. So context really matters here, and I'd recommend that we consider the context of the contact and the quality of the contact when assessing risk. It might be short, but if your voice was raised to speak, let's say, over loud machinery, or the other person was coughing or sneezing during that encounter, you might decide to err on the side of caution in terms of saying that was a high-risk contact. Explaining to people your reasoning here is really important, because sometimes people feel like it's kind of arbitrary, but when you explain it to them, it helps them understand your assessment. It also raises their awareness that their contact with other people depends on the context and the quality of the contact. The less than 6 feet and more than 15 minutes rule is a starting point, but it would be irresponsible for any of us to interpret it so rigidly that you could inadvertently perhaps do harm by not quarantining someone who may have had, per your assessment, a high-risk exposure.
That's very helpful. And then our next question is also for you, Dr. Brooks, and I think this might also speak to a question that Tina asked in the Q&A box in kind of a, they might be slightly different, but also along the same line. So we heard a lot this week in the news about CDC changing recommendations for going back out into the world after being sick with COVID-19. Can you explain the new guidelines?
Yeah, I'd be very happy to. So we've updated our guidance on isolation and precautions for adults who've been diagnosed with COVID-19. That means you've been either told that you had a positive test, or a doctor or healthcare provider said, based on your clinical symptoms, the way you look to me, you have COVID-19, even if they weren't able to get a test. And we now recommend using a symptom-based and time-based strategy, and we're no longer recommending using a test-based strategy to end isolation or precautions, except in some very special circumstances. So I want to be very clear. What I'm saying here is we still recommend using the test to make a diagnosis, but we don't recommend using that same test to determine when somebody has gotten better and is not at risk of exposing others or transmitting to others. Now, first of all, let's talk about what this isolation means. If you think or know you've had COVID-19, then, like in the circumstance I described before, a doctor tells you you've got it, or you have a test that says you've got it, then you can stop the isolation 10 days after symptoms first appeared. So the first date on which you had any symptom, a sore throat, diarrhea, headache, whatever the first one was, 10 days since that date. And at that time, 10 days later, you have not had a fever for 24 hours, and that has to be a fever where you weren't taking medication to suppress your fever, which I know is tempting for some of us, but it's gotta be a fever without medicine, and your symptoms also need to be improving. There are a good number of people, we've talked about this idea that there can be people who are infected but never develop symptoms, but they may have a positive test. And so if you don't have symptoms, how do you start counting where that date of illness onset was? In that situation, start from the date of your positive test. People, now this is going to apply to the vast majority of people. We know most people with COVID have mild to moderate illness, but there are people who have been very severely or critically ill. And there are some data, it's one report, so we need to look at it carefully, but there are some data that suggest for the most severely ill and critically ill people, they may need to isolate as long as up to 20 days. And since that's an unusual circumstance in general, we really urge that people who are faced with having to manage this situation, consult with either an infection control expert or an infectious diseases expert to guide them through making a decision around the situation. This symptom-based strategy applies to most people with COVID, as I mentioned, but with one exception. This is an important exception, and that's for people who have severely weakened immune systems, who may still need to be tested after their diagnosis to understand if they've cleared the infection. We don't yet know if it takes longer for severely immunocompromised people to clear the SARS-CoV-2 virus, which causes COVID-19. But based on our experience with other bacteria and viruses in people who are severely immunosuppressed, and the fact that they can continue to shed these for a long time, we're very concerned. So these can also be difficult cases to manage. Hopefully, they're not the kind of case you're going to be encountering in your routine daily life, and are generally cases that you're seeing in a hospital or in a special setting. And for that reason, we recommend they also be managed in collaboration with an expert in infectious diseases or infection control. But for all other persons, a test-based strategy is no longer recommended, with one other small exception, which is that if you're in the very unusual circumstance, you want to or you need to see if that person can come out of isolation before 10 days are up. Sometimes people are working in an area where they just have to get out as soon as they can. There, testing could possibly be used judiciously to see if they are no longer positive before you reach those 10 days. So that would be the other place. Now, this is an important point I want to make here, and I hope a lot of you understand this, and so I apologize if I'm repeating something. But ending isolation is different from quarantine. Isolation is used to separate people who are known to be infected, so either they had a positive test or they got a diagnosis from a doctor, and to separate those people from people who are not infected. So we want to help that person who's infected both get proper care and separate themselves from other people to stop the chain of transmission. And this new recommendation for isolation does not impact our recommendation for quarantine. Quarantine is used to keep someone who might have been exposed to COVID and might be infected away from others. We quarantine people to help prevent spread of disease that could occur before the person knows they're sick and if they are infected with the virus without feeling symptoms. So what I'm getting at is that anybody who's been in close contact with someone who has COVID-19 and is considered a high-risk contact needs to quarantine for 14 days and monitor themselves for symptoms. And I know 14 days is longer than the 10 days for isolation, but I'm going to tell you the reason why it's 14 days. It's this. Based on our best knowledge about the virus that causes COVID-19, we now know that the time it takes from a high-risk exposure to developing illness that you could transmit to others can vary from as short as 2 days, but it can take all the way up to 14 days. So it's really important that you quarantine for the full 14 days and monitor yourself for symptoms before being around other people again. And by the way, if you do get symptoms while in quarantine, of course, contact your healthcare provider or hopefully the public health authorities helping you quarantine to let them know you might want to get tested. All right, what counts as a close contact? Well, I've already introduced the rule about 6 feet for 15 minutes, so discuss that, we won't go further. Close contact is also defined as having taken care of someone with COVID-19 at home. So if you have a sick child or a sick spouse or a sick elder at home, that taking care of them would meet the definition of close contact. Or you have been in direct physical contact, it doesn't matter how long, physical contact with a known infected person. And we define contact as touched, hugged, or kissed. Or you've shared eating or drinking utensils with an infected person. So you all shared a meal together, you passed plates, everybody took food out of the same container with the same spoon. That's close contact. And lastly, as I alluded to when I was describing the 6-foot rule, if someone has directly sneezed or coughed on you, that's close contact. And remember that this applies to all people who've been diagnosed as infected, both people who were sick as well as people who were diagnosed with the infection when they had no symptoms. And usually, if you may not know it yourself, part of contact tracing, where the public health folks go out and help find people who've been infected in their contacts, someone may reach out to you from public health to say, hey, you may not know this, but so-and-so, or you may have had we think you've had a contact with a person that was risky. That may be another way that you find out. If you see that the public health, if someone from the government is trying to call you, I know we're all a little sketchy these days, as we are pretty much all the time, perhaps. When the number pops up on your telephone, it's the government, and I often think it's the IRS. But this is a time that you really should answer, because we're trying to help you learn that if you've been exposed, what we can do to help you from potentially not infecting other people. All right, I know it's been a lot of information. So, Erin, should I share an example of a situation about that illustrates what I'm talking about?
I think that would be helpful. And then, then I have a question for Dr. Walker, but yes, that would be helpful.
Okay. So I don't want to burn up too much time, but let me give you a concrete example that may help you. So let's say there's been a party on July the 4th, and you went to this party, and it was a backyard barbecue party. And I'm going to be the outside observer, and I'm looking at this party, and there's person number one. And person number one started to feel sick and developed symptoms of COVID 2 days later, on July the 6th, got tested and is positive. So person one now has to isolate at home for 10 days since the date they first got symptoms, which happened to also be the date they got tested. So that would be 10 days. So that person has to remain isolated, remember isolated because they're sick, through July 16th, 10 days later. And that's as long as by July 16th, they've also been free of fever for 24 hours without medicine, and they're starting to feel better. They're okay to leave. Now there's a second person at the party, and that person hears through the grapevine, because we're all friendly, that there was a friend of theirs at that party who tested positive for COVID-19. And then person two realizes when he learns more that he spent part of the afternoon together with that person number one. And some of that time was spent within 6 feet, and they weren't wearing masks like they know they should have, but you know, it happens. Even though they're not feeling sick, person two decides to get tested, let's say on the 8th of July, and the test comes back positive. So person two, even though their infection has not got any symptoms, needs to isolate now for 10 days since the first test. That's where they start counting. That would take them to July 18th, 10 days to July 18th, because they're isolating due to a positive test or having been told they were sick. Then there's a third person. Person three only spent a little bit of time with persons one and two that afternoon, but definitely chatted with both people for 15 minutes within the 6-foot zone. And even though person three doesn't have any symptoms, they had an exposure where they could have been infected. Person three needs to be quarantined at home and monitored for symptoms of illness for 14 days after their last contact with anybody who was anybody they had contact with who also was diagnosed with COVID at the party. Person three never developed symptoms, and they're done with their quarantine 14 days later, or July the 18th. And of course, if they develop symptoms during quarantine, they should be tested. So let me stop there and see if that's helpful, Erin.
Yeah, somehow the math works out, and I'm pretty sure I saw them sharing like chips and guacamole. So that is interesting, and I'd never actually thought through how the math works. So thank you for helping me through that. I really appreciate it. And I hope that was helpful for everyone else too. Let's see, I was going to ask, if I could, a question of Dr. Walker. In terms of traveling, what should I do if I start experiencing COVID-19 symptoms while I'm away from home?
Sure. I can talk to you that, and I can actually use Dr. Brooks' example, because a lot of people do travel over 4th of July weekend, maybe to see friends or to attend parties where they may not have been 6 feet apart. So let's go back to his example where there is a person who did develop symptoms. And let's say that they weren't in their home community. They were away from their home community. So if that person did experience symptoms of COVID-19, because many people are able to recover without seeking medical care or being hospitalized, that isolation that Dr. Brooks just talked about would come into play in this scenario. So if you experience symptoms of COVID-19 when you're away, you do the exact same thing you do when you're home. You isolate. You stay home if you're at home, or you stay in whatever home or lodging that you are occupying. except if you have to get medical care. We don't want anyone who is experiencing symptoms or exposed in quarantining to be out moving through, driving through and going to rest stops or getting on an airplane or getting on a train. We would want everyone to stay isolated or quarantined if just exposed without symptoms or a positive test. And if that person is experiencing symptoms, monitor the symptoms, make sure that you have an emergency warning sign, including trouble breathing, that you seek care immediately. Stay in a separate room from other household members if possible, because you would not want to expose your family members or traveling companions. That includes using a separate bathroom if possible, and avoiding contact with other members of your traveling party, your household, and any pets that are with you. We would recommend not sharing personal items like cups, towels, or utensils. And again, wearing that cloth face covering or mask when you're around other people if you're able to. And as Dr. Brooks just went through, generally you can be with others again after at least 10 days have passed since your symptoms first appeared, and at least 24 hours with no fever and no fever reducing medication, and seeing that your symptoms have improved. So I hope that sheds good light and shows you what you can do and how similar it would be when you're at home or when you're away from your home. It's the same steps that you would take.
Yeah, absolutely. One more question for you, Dr. Walker. Is there anything I can do, or what happens if there is a sick passenger on my flight, should I happen to be flying anywhere, which I don't plan to do in the near future?
So we do know that traveling in general presents a risk, and it's always safest to stay at home during the pandemic. But if you are on a flight and there's a sick passenger on your flight, under current federal regulations, pilots must report all illnesses and deaths to CDC before arriving to a U.S. destination. And according to CDC disease protocols, if a sick traveler is considered a risk to the public's health, CDC will work with local and state health departments and international public health agencies to contact exposed passengers and crew. So what you can do as an individual is to be sure to give the airline your current contact information. As Dr. Brooks said previously, you see a phone number popping up on your cell phone and you don't know it. A lot of people don't answer it, but this is, again, a really important situation where you need to answer that phone. So a lot of this information will be collected when you are booking your ticket, and it allows you to be notified to let contact tracers know, let you know that you've been exposed to a sick traveler, and let them follow up with the appropriate public health protocols. And if you want more information on this, you can look to the CDC's webpage for protecting travelers' health from airport to community, investigating contagious disease on flights. And that will give you a lot of guidance in this area.
Thank you for that. I have a couple specific, or a little bit more specific questions. Dr. Brooks, does CDC have any guidance about going to the beach? I have questions about this and like pools and all that sorts of stuff, because I have visions in my head of being able to go back to a beach someday. So
Yeah,
do we have specific guidance about going to the beach?
Yeah, actually, we do, but it really brings up the bigger question that I think a lot of us are asking, which is, is it safe to travel? Is CDC saying we shouldn't travel this summer? Mm-hmm. And we all know that traveling, in addition to being important for business, is also remarkably therapeutic. I mean, many of us, I shouldn't say all of us, but a lot of people look forward to getting away or visiting friends or going to a reunion or just going somewhere different after being in their house for 4 months.
Right.
And so we're not saying you can't travel, but we want you to do it safely. And that's really what this game is all about. And right now, when the prevalence of the infection is high, the risks are a little higher too. So if you can defer travel, we'd recommend that. But still, if you're going to choose to travel, we want to help you do it safely. Now let's talk about going to the beach. It's a great place. I want to give you 2 rules of thumb when thinking about this situation and others. The first is that the closer and the longer you interact with people other than those you normally reside with, the greater the risk. All right. So basically, the people you reside with, you can assume that if it's your household and you're feeling okay and everything is fine, you're all in a bubble together. But the more that you are closer to and interacting with people outside your bubble, the more your risk is going to go up. And then the second factor is the higher the number of new infections in the community where you're going to, where you may be residing during your vacation, the greater the likelihood is that you'll encounter someone who may be an infected person and you may be exposed to them. Now, unfortunately, there is no app or any other way to calculate your risk in every situation. We all like to be able to do that. It's fun, but in this situation, it really is having to use your judgment and do what you feel comfortable with in terms of the amount of risk that you are willing to tolerate. All of us have different levels of risk tolerance. So here are 3 scenarios I want to lay out how the risk of spreading the virus at the beach ranks from low to high. So let's start with what I would call a low risk scenario. This is one where the lifeguard and the visitors and everybody else at the beach stay 6 feet apart from people that they don't live with. So you may have a beach umbrella and some towels and chairs with your family, but you all are clustered away from everybody else by at least 6 feet. Staff and beach visitors don't share food, don't share equipment, toys, supplies, anything with the people that they don't live with. Fine to share buckets to build sand castles with your kids in the family, but don't share with anybody else. And ideally, there's a breeze, which not only is probably going to make it a little more comfortable, I hope, if it's not cold, but because ventilation can increase the risk of getting infected from the air around you by thus decreasing the amount of virus you might get exposed to. And we can come back to talk about the whole air thing and ventilation a little later if time allows. It's a low risk, what else to just say, but it's one that it never hurts to have a little fresh air anyway. All right, let's go to the next higher level. So now we get to a situation where the staff and the folks are closer together. The beach is crowded, and so you are forced to be a little bit less than 6 feet from other people that you don't live with. But they're all people who are from the same area you are. The staff and the beach visitors limit their sharing of food, equipment, and toys or supplies with others, so they may only share with people that they know. So let's say you recognize a family from your community, you're coming from a low-risk area, you recognize a family from your community 10 feet away, so you all may saddle up and get within 6 feet of them. But anybody you don't know or anybody who maybe you know may be coming from a place with a high prevalence or high number of infections, you'd want to try and avoid them. And then the highest risk is sort of some of the pictures you may have seen in the news where everybody's within 6 feet of each other. Everybody from different towns and different parts of the country are mixing together. And maybe people are even, sharing their food and equipment and toys very freely with others. So that really forms the highest risk situation. So as Dr. Wallace was getting at earlier, if you know you have symptoms of COVID, don't travel, stay home. Or if you're waiting for the test, you think you might be sick, you got tested, wait till you get the test results before you travel. Always look to see if in case you're going to a swimming pool or a water playground or a hot tub, that they have measures in place to prevent exposure to infection. A lot of pools now limit how many people can come in, how the lanes are arranged, number of people that can be in the pool. Bring supplies that will help keep you and others safe. So for instance, bring a cloth face covering or mask to the beach with you. In fact, you might want to bring 2 because in case one gets wet, you'd like to have a dry one. Have hand sanitizer and make sure that it has at least 60% alcohol in it, disinfectant wipes, tissues, and paper towels. When you're in the water, just like when you're on the land, stay at least 6 feet apart from other people. And as I was trying to get at earlier with the examples, avoid crowded beaches, pools, water playgrounds, and hot tubs where you can't stay 6 feet apart from each other. Don't wear a mask or face. This may sound obvious, but just in case, don't wear a face covering or mask while you're in the water. We don't want it to contribute to you possibly drowning. And we also recommend in general not putting a face covering or mask over a child under age 2 or anybody who that thing on their face may make it difficult for them to breathe. Either they're unconscious, incapacitated, or unable to remove it without help. These face coverings are especially important when social distancing is hard. Wash your hands in soap and water for at least 20 seconds, especially when eating and drinking, when you arrive and leave the swimming area. And just know that if soap and water aren't available, hand sanitizer is fine, but you need to rub it until your hands are dry to get the most effect from it. And it's not as effective if your hands are visibly dirty. So if you have visible dirt or grease or sand on your hands, wipe that off if you can with a paper towel before you use the hand sanitizer. And if you're not wearing a face covering, make sure that when you cough or sneeze, you either sneeze into a tissue that you dispose of or sneeze into the inside of your elbow, and then wash your hands thoroughly afterwards. So there you go.
Thank you. That's a lot of helpful information. And I've got, I've got 3 boys, and we've tried to make it to a couple of pools where we knew we were outside and we could socially distance. And so that's really good information. I've got one for Dr. Walker, and then I think one more for you, Dr. Brooks. I know this session, Dr. Walker, is more about domestic travel, but do you have any guidance for us about potentially traveling internationally right now?
Sure, we do. CDC has lots of guidance about traveling internationally.
Always.
Always. In general, we have our travel notice system where we can alert you to any health threats or risks abroad, and that's an ongoing service that we provide. Currently, though, because of the pandemic, we do recommend that you avoid all non-essential international travel, and that is our level 3 travel health notice. Some healthcare systems are overwhelmed, and there may be limited access to adequate medical care in affected areas at destinations. Many countries are also implementing travel restrictions and mandatory quarantines, closing borders, prohibiting non-citizens from entry, and these can change or be put in place with very little advance notice. So if anyone chooses to travel internationally, travel plans can be disrupted, and those people may have to remain outside of the United States for an indefinite length of time. So these, again, are unexpected issues that may arise if you're planning international travel during the pandemic. Some countries are also conducting exit screenings for international travelers that are leaving their country, and before being permitted to board a departing flight, you may have to have your temperature taken and be asked questions about your travel history and health. And if you do return to the United States from international travel, you may also be screened when you arrive in the United States. Even if you're not, after your arrival, you should take the following steps to protect yourself. There are a few things that we ask. As we talked about a little bit earlier, this journey that you've partaken in, traveling internationally, is a risk, and we know that there's a possibility that you have come in contact with others, been within 6 feet of others, not been able to maintain that social distance, possibly not worn a mask at certain time periods. There are all types of risks that you have that have been in place that are outside of your normal activities. So we recommend that you stay at home and avoid contact with others and not go to work or school for 14 days. And that while you're doing that, you monitor your health for those 14 days, taking your temperature with a thermometer 2 times a day and monitoring for fever, and also watching for cough or trouble breathing and other COVID-19 symptoms. We recommend that you keep your distance from others at least 6 feet or 2 meters and wear a face cloth covering or mask when maintaining that 6 feet of distance, or when maintaining that 6 feet of distance isn't possible. There are lots of other travel frequently asked questions, especially about international travel, that you can find on CDC's website. So please feel free to look those up, because this is the question that gets asked quite frequently.
Yeah, absolutely. And I think we have time to squeak out one more question for Dr. Brooks. This one's again from our Q&A box. So once you've contracted COVID, can you spread it again later? And I'm assuming this would be after having a negative COVID-19 test. Mm-hmm. Are you safe to be around your family who may be at higher risk?
Yeah, you are. And let me explain what that means. All right, so what we've learned a lot. I just want to remind everybody, sometimes we forget that this virus has only been with us for 7 months. For some of us, it feels like a long time, much longer time, but it's really only 7 months, and we're still learning a lot. And that means that there's also a lot we have yet to learn that we don't yet know. One of those things is how likely is it, or is it possible for you to get reinfected? Well, I think there are a number of things we can say based on what we've learned so far, and one of them relates to, do you pose a risk to your family once you've gotten over the infection? One of the reasons we've stopped recommending using that PCR test for diagnosis to see if you've recovered from the infection is that we've learned that even though most people, stop shedding live virus after about 10 days, they can keep shedding dead parts of the virus that PCR test can pick up and register. So they'll have a positive test, but it's not because there's live virus there. It's because as part of their recovery, they're still shedding some of the genetic material that the test is designed to detect. So it's giving you, it's not giving you a result that's helpful. It's telling you that you might have it, but in fact, we know you don't have it. So we don't want people to keep using the test for that purpose, because it's led to people being kept out of work, kept in their house when they didn't need to be any longer. What that also means is that we think that people after that 10 days are not at risk of infecting others, at least for 90 days after their date of infection, or if they never got ill, the date of their first diagnosis. And how do we know this? We know this because some really nice studies that were done where they took people who, in these studies that I'm going to talk about, had 2 negative tests after they'd recovered, and then who later had another positive test. So they take people who, after they've gotten better, have a positive test, what they were calling a re-positive test. And many of those people got tested because they had symptoms again. They had an illness or something come up, which could have been something else. And I think as we look towards flu season, we're going to need to think a lot about that. But they got tested again. Well, here's the good news. First, among hundreds of these persons who they found all of their contacts from that time of re-positive and put all of those contacts into quarantine, that was over 790 people, I think, were in quarantine from 285 people who were re-positive. Not a single one of them developed an infection related to their contact with the infected person or the re-positive person from the time that they had a positive test again. So that's really good epidemiologic evidence that they weren't transmitting. But even better, for 108 of those people, they were able to take their specimen and try and culture virus from it. And those were specimens collected as long as 83 days after their onset of illness or date of diagnosis, and none of those grew any virus. So we feel reassured that, at least shortly, and this is consistent with what happens with a lot of other viral respiratory infections, that in the short few months after you've been infected, you're not at risk of getting it again, and you're clear of the infection, you're not going to transmit it to others. We hope that nobody's going to get it again, and that the immunity that we have from the natural infection is going to be durable. But we're very cautious, we're looking hard, and there are public health professionals and clinicians all over the world looking to see how long immunity lasts. And hopefully it's for a good long time. But right now, we can only say that it's up to 90 days that you don't need to be particularly more concerned about reinfection and passing it to other people. After that, we don't know. And we would recommend that people at that point, maybe if they have symptoms, again, from something else, consider getting retested.
Thank you so much for that. I learn an incredible amount every single time we do one of these. And I really want to thank Dr. Brooks and Dr. Walker for spending their time here with us today. And thank you to everyone who has joined us today for this webinar and taken time out of your day to continue learning with us. Our recording will be posted online on CDC's COVID-19 webpage. And again, the subscription link to receive future updates and invitations is listed in the chat box. So go ahead and click on that if you're not already signed up to receive all of our information. And that concludes our time together. Thank you again for joining us. Next week, we will be discussing CDC's health equity strategy. So we look forward to you joining us again. Thanks, everybody.